There we go. So, Colby, please feel free to share slides or whatever you need to do, and we kind of are just settling in and welcome you to edify us.
Awesome. Thanks so much, everyone, for having me again. And I'm excited. We're gonna do 15 minutes, right? 15, the plan?
15 overview. You can
Okay.
slide that to 20, maybe even 20 something, because altogether we do about 40 minutes each because of probable questions and discussion afterward.
Amazing. Well, I'm excited to share more. Uh, so again, my name is Kobe Takeda. I'm originally from Hawaii, actually. So it's everyone always finds it interesting when they hear I'm now based in Tulsa. So very different, but I really welcome the community there, and I've been enjoying learning all about the Heartland and the different challenges and opportunities to support, especially with rural health, with community health workers, with the different healthcare challenges in these areas, and but certainly do work across the country as well. I originally started off working at the Blue Zones Project, doing things like food, housing, and transportation policy, understanding how the social determinants of health impacts health outcomes and helps health plans and health systems improve community health and well-being. I was actually there when I was teaching community health worker courses, and it all came together where, I recognized the need for more integration and support and collaboration across the silos, the health plans, the health systems weren't necessarily working with community health workers well. And community health workers, specifically those based in the community, community-based organizations, nonprofits, weren't partnering with health plans and health systems. And so we recognize some challenges there, and we wanted to address them. And so we launched Pear Suite in 2021 to address that. Team has grown quite a bit since then. We now have about 32 employees across the country, supporting different ways, as well as some exciting new things with our provider network. So I'll share more about that in a bit. I've also got really involved in the community health worker kind of movement, this exciting, really innovative, forward-thinking workforce is changing healthcare, I think, and making really big waves in the healthcare ecosystem. They're partnering with health systems, they're addressing HEDIS and STARS metrics, they're saving the healthcare system money, they're taking on value-based contracts. It's pretty exciting to see. So I'm becoming a kind of thought leader in this space and how to bring these two sectors together. There's a piece I wrote recently for Med City News about the emergence and exciting workforce that is community health workers and community-based organizations. Our company was recently recognized by the um, uh, Hub Foundation, Health Hub Foundation, for being a rising star in the health equity space. I also joined the board of the National Association of Community Health Workers, really to bring my insights and expertise working with health plans and health systems. For a lot of community health workers, this is new. How to, talk like health plans do, how to think about what health plans care about, how to align interests. This is a big challenge for many organizations. I'm also a certified community health worker in about 7 states now, including Kansas. So I've and actually interestingly, Kansas and Missouri have a shared agreement that you can actually use your certification across state lines, which is really unique. So I work across multiple states, and we do projects in about 39 states now. But my with some of the work we did in the past, I had to get certified. So I am certified in Kansas, which is really great. Um, Pear Suite also participated in the Nexus project program last year. And so we were down in Wichita doing some work and started some relationships with the health plan there, as well as some other local community-based organizations. And we also started doing a lot of work with doulas and other frontline workers. And so think about anyone, they might not be called community health workers, they might be called promotoras, they might be called care coordinators or navigators. It really is a diverse workforce, and we're so excited about them. And I think one, the pandemic, helps people recognize the value of community-based providers, the trust they build, the understanding of community resources, their ability to build connections and get people to do things that the healthcare system traditionally couldn't do. Health plans still send out postcards and try to use that to get people to get vaccinated, and they wonder why it doesn't work. And well, it's because there's no trust built in that. You need that personal connection, and that's what community health workers do so well. So it's so great that so many of you are on the call today who can represent that perspective. So yeah, we're excited about the hundreds of CHWs and other community providers that are already working across the heartland, and many of them that don't call themselves this, but they are there. There's probably thousands actually, and many of them are just starting to work across sectors. And so, how do you, sometimes they're based in nonprofits or public health agencies or maybe health systems, but really, do they kind of communicate and collaborate? And I think a lot of that is part of the challenges that we're trying to address. And so actionable data is one of the biggest things we think is the key to unlocking these relationships and these partnerships, and also funding. If you can use data to show health plans, health systems, other funders that you're making a difference, you're addressing the social drivers of health, their social challenges, and tying it back to things that health plans care about, like HEDIS and STARS and quality gap closures, all the things that we know make a difference in the bottom line for health plans that really have the money. You can really, one, address some of these biggest challenges and increase impact, but also align it with financial incentives and funding streams. Of course, there's extensive challenges working across sectors, right? We know that some organizations are still on paper and spreadsheets. Community-based organizations aren't familiar with compliance. They've never submitted claims before, or even may not know what an NPI is. And certainly for a lot of community-based organizations, they've never contracted with the health plan. And so just to share more about with the current situation across Missouri and Kansas, Missouri currently doesn't have a Medicaid reimbursement pathway. They do have a credentialing pathway, so you can get credentialed as a community health worker. Kansas does have a Medicaid pathway for reimbursement. But when and I traveled quite a bit to Kansas, the last conference I was at, I didn't meet a single community health worker there that was billing through the billing codes. And so it's just a lot of barriers and challenges. There's a lot of policy that's coming out and a lot of consultants coming in, but no one's really tying the policy back to implementation and acting on it. And that's kind of the work we do across the country. And so I'll share more about that in a bit. There's also new codes for Medicare reimbursement that's actually available across the country, and it started in 2024, and we're helping groups execute on those billing codes as well. So, recognizing all these challenges and these barriers and understanding that, community-based organizations just haven't done this before. We launched Pear Suite as an AI-powered platform for community health workers. We think that AI is an opportunity to empower and uplift this workforce, not replace them. And if we can make it simpler for them to do their job, if we can reduce the redundancies and the stressful aspects of their work, we can reduce the strain and tedious parts like documentation, doing long assessments, doing claims. We can really uplift this workforce and help them be more sustainable. So our platform is completely customizable. It's simple. Community health workers love it. They think it looks really great. This is actually the back end, so we can actually build out custom workflows, tying in things like automatic text messages or creating goals for members based on how they respond to different questions. So we're basically using data to drive the workflows. And this can help assist the community health worker understanding what those social needs are, what those healthcare gaps are, and how to fill them in meaningful ways. We have a suite of navigation tools, so community health workers can actually get assistance in real time with suggestions and recommendations about what care programs might be offered or may be appropriate for a member based on their background, their location, their language preferences, their health plan. We can do these recommendations. It will pop up and suggest programs like SNAP benefits. If someone identifies a social need, you can create goals and you can track them in real time and add action steps to kind of track how you are doing and getting those care gaps closed. We have assessments, you can take notes. We even have a phone system and texting platform built in. So you can actually call them in real time and talk to them and track your time spent, which is an important key aspect of billing. You can, of course, text them information or send them referrals or even send them websites or information via text. Of course, data is huge. The people that have the money want to see data and want to know that the money is going toward good, impactful work, whether it's a foundation or a grant or a state agency or a health plan. They want data, and so our platform allows you to track all the work you're doing across your team, across your organization, across multiple organizations. We also support hubs, so multiple groups coming together to get support, maybe administratively or fiscally or contractually, and helping smaller organizations do this work. We can actually track data across multiple groups. But being able to see the breakdown of goals or impact or work you're doing has been really key. And then, of course, something that a lot of case management systems don't have is a claims piece. Like being able to stay in one system and not have to export data for one platform, whether it's your own HubSpot or maybe another case management system to upload it to then a clearinghouse or some kind of billing system. It's just a lot of work and there's a lot of challenges with that. So our system allows you to submit claims right in our platform. We can create specific integrations with the different provider portals, so you can actually check eligibility of a member from our platform. You can resubmit claims or correct claims from our platform. You can fill in different gaps around the address, the phone number from our platform. It's really a one-stop shop for all organizations to do their work. We also, we started off as a software company after doing this work ourselves. So we actually had a services team for a long time, and we still do. We have community health workers that do work with health plans. We built software and we said, hey, we're going to be a software company as well. But we realized that we can't just be a tech company, right? Tech companies alone aren't enough to get the engagement and to address accessibility in the ways that gets adoption. So we actually built out a wraparound support team that helps organizations using our software to do this work, right? We wanted to help them make sure that they can get the care and support they need to do credentialing and contracting and claim support. So now we help organizations that use our software bill with Medicare and Medicaid and other health plans. We help them negotiate contracts. We help them get the training and technical assistance to do compliance and manage audits, prepare for clinical review. If they need support with having a provider to do recommendations or to write letters of support for members that need assistance with clinical care or CHW care, they can do so as well. And of course, we bring these groups together for collaborations. So we built out a provider network, basically a medical group, to allow for this work to happen across the country. And now organizations that may not have the clinical staff, like a licensed practitioner on their team, can still get the care and still get the claims submitted because we have a medical group that can support them and help them bill. So we are now in network with about 22 health plans, allowing them to bill all across the country. And we can easily get in with network with other health plans, allowing groups to bill with Medicare as soon as we get a network with them. So we can actually subcontract out these organizations and allow them to bill through our NPI. In our provider network now, we have about 150 different organizations that are billing through us, and that's about 850 providers. So we're impacting a lot of lives. We're helping people get paid faster. It's really, really great. So again, we have two sides of the organization, two offerings. We have some groups that just use our software. They just want to document and track their work. And our system is a great tool to enable them to do that. But if they need the enablement support, they want wraparound assistance with things like claims, getting compliance, doing credentialing, assistance with contracting with health plans. We also provide that. And that combination is allowing organizations in the matter of 3 weeks. And that's how long it takes to implement our software. It's very simple. You don't have to pay for a long implementation. And we actually don't charge for implementation. You just pay our monthly subscription, and you can get paid for the work you're already doing in a matter of weeks. And so that's a really huge benefit for these organizations. Just to share a case study and kind of why this is so important now, especially with some of the challenges we're seeing. Thrive and Colony and Kansas Cares is one of our partners in Kansas. They got a huge grants last year to launch a healthcare navigator program, $11.9 million. So we actually are onboarding right now about 12 different organizations across different counties in Kansas and Kansas City. And it's been great. We're onboarding about 45 CHWs and navigators. This has been really exciting for the health plans because the health plans have been trying to do this work and they just don't know how to work with community-based organizations. Sometimes they struggle with finding these groups. They don't know how to contract them, or for them to have to explain what an NPI is to these groups and how to submit claims is kind of exhausting for contracting teams. So they just don't do it. And so our ability to onboard and be that liaison has been huge. Unfortunately, they are losing quite a bit of their funding. So, some of the challenges we're seeing right now and the restructuring at the national level has forced them to lose 90% of this grant. So it's pretty devastating for them, but it actually supercharged and is making them more excited and enthusiastic about figuring out how to bill. Because if they can actually transition from grants to sustainable revenue through reimbursement, both through Medicaid and Medicare, this can sustain the program. This can allow them people to keep their jobs. This can allow the program to grow. And so we are expediting their onboarding to be able to become a billable entity, and we're helping them do so. Um, Otherwise, across the country, things are going well. We have about 200 customers across the country. We have 98% retention, which is great. That means they love the software. They don't just start and quit. And then we're growing pretty fast, and so we have great growth. We onboard about 20 organizations a month right now, and you can just see the diversity of organizations. It's health plans, it's health systems, it's community-based organizations. We're onboarding some large health systems right now. We're working. Our specialty is really small organizations that may not have an EHR already, and so and you can kind of see our footprint here. This actually might be in a little outdated map, but yeah, we're growing. And of course, the results speak for themselves. We're helping organizations increase engagement with members, which people really care about. We're helping them not just engage and talk and share information, but get them to do things that helps improve their health outcomes. So connecting people to resources, helping them get connected to a doctor, that's all really important. And we're also increasing efficiencies. We're helping organizations do more with less and be more efficient. Of course, that efficiency leads to better claims. We have a very simple, I won't go too much into this because I'm not trying to sell anyone here, but we have a simple pricing structure. It makes it really easy for organizations. We don't lock people into multi-year contracts. It's strictly month to month. We don't charge for implementation. We don't charge for extra support. It's all included. And it's really accessible. We make it really cheap. And I promise you, we've never turned anyone away because of price. We have some groups across the heartland that could only afford $25 per month for the entire organization. And we say, that's fine. Let's help you out. So we work with some groups that, work with promotoras that are undocumented. We don't charge them at all because they don't get much money from this and they can't get paid from this. We really make this accessible, and we are an impact-driven company. So we want to make sure that people have access to this information and this work. And of course, our platform is very flexible and supporting a lot of different types of work. So whether it's integrating with health systems or doing different assessments, we can work with all those different types of forms. Yeah, and there's some national partnerships. So we work with some foundations. We work with Heartland Forward, which is really focused on data, and work with some other organizations across the country. And that's a quick overview of the Pear Suite platform. I really appreciate the time, and I'm looking forward to opening it for questions and having a discussion about what we do and how we can maybe support some organizations across Kansas and Missouri.
That's great, Colby. Thanks very much. Very informative. Though I probably have a ton of questions and I'll try to keep them short so others can chime in. But you might just, for the benefit of everybody, say a little bit about the NPI and why that's important in the reimbursement place.
Yeah, a lot of challenges around understanding how billing works and how provider groups work and how contracting works. Essentially, there's some policy that comes out every year and it tells you, these new codes are available, but a lot of organizations don't understand how to use the codes. They've never had to work with health plans. They never had to contract. They don't have to credential. And certainly there's pathways and some assistance here and there, but putting it all together is really challenging. There is actually a new provider type that's available now at the national level that is an individual CHW. Not every state requires that, though. So you don't actually have to have an individual NPI. In Kansas, you actually don't have to be, and for Medicare reimbursement, because it has to go through a clinician, you don't have to have an individual NPI. You have to have a group NPI. So actually, and in some states, you can actually be a community-based organization and bill. Unfortunately, that's not available right now in Kansas or Missouri. You can't be a nonprofit and be a billable entity. So you can't apply to be have an NPI, a National Provider Information Number or something like that. NPI, what does that stand for? Anyway, it's this
National
number.
Provider
Yeah,
Identifier.
there you go. Thank you. So you get this number. It's free to get, but it's just, not everyone, people are always wondering, do I have to get one for the organization? Do I need one myself? You can apply to be an individual provider, but it's not required for billing with Medicare because it's all bills and claims all go through specifically for Medicare and Medicaid in these states through a provider, either a group or a clinician, individual clinician. If you're a CHW that's based in a clinic, for example, you can bill through your clinic group, or if you're based in a pharmacy or working in a hospital system, those are all billable entities. But those who are based in community-based organizations have to find a provider group, which is something that's why we try to bring people together and build partnerships where you can maybe bill through a local FQHC or a local clinic. Of course, that comes with its own challenges because now you have to share data. You have to understand, how these billing codes work. But yeah, that's just a kind of overview of the MPI importance.
No, that marks a real change in the environment, and it's important for especially our CBOs to know about that.
Mhm.
Um, could someone conceivably contract with a provider who has the MPI for those services and be reimbursed from the provider for having done so?
Yeah, of course, and that's just becomes a question around how do you facilitate the payment, right? Yeah, are they a subcontractor or the employee? What's that employment relationship? How do you make sure it's not a kickback? Maybe you charge a percentage-based fee, and it's more like a provider fee. You want to make sure you're abiding by laws. We subcontract out. We have a subcontractor provider relationship with all of our community-based organizations that we bring into our network. We'll take a small percentage as an admin fee. Either it's usually 5 to 10%, just to support them with clinician review, audit support, the contracting. We do all the claims for our providers. But yes, we do bring people together. And actually, in some states, for example, in Kansas, an FQHC can't bill the community health worker benefit because they have their own PPS payment model. But if those CHWs are working in an FQHC setting and not overlapping with the work of available time-based PPS model tracking of an encounter, you can actually have them potentially work for another organization or be based at another organization that can bill. So this is how we can sustain community health workers and help them get paid more and make this less about grants moving around left to right. We can kind of sustain the workforce.
That's a tremendous service. Your ability to lead people through that will be very important, I think. Okay, I'd like to open it up for others to ask questions. Please go ahead.
Hey, Colby, it's Dick. I am fascinated by your interest in setting up your own provider network. So, um, a lot of these early stage companies that we work with find themselves drifting into what I would call a tech-enabled service. So they've just learned that being pure tech, trying to change behavior is really challenging. So they end up having to either, put something on the back end or front end, and which way you tend to look at this. But tell me about the decision to do that. I think that's something other early stage companies are like, do I actually go into the provider business? So I'm
Yeah,
fascinated
good
by
question.
your company's decision to do that.
Yeah, we actually there's this natural flywheel effect that happens. We actually were really, really good at starting with getting the community-based organizations engaged. And then we realized the health plans were trying to do the exact same thing. They just didn't know how to. And so when they realized that we could, build the trust and we can onboard community-based organizations in a matter of weeks, and they actually liked the software, like it wasn't Epic, it wasn't this, gnarly thing that they didn't know how to use. They started paying us to do that. And so the health plans started paying actually for the software costs for organizations because they wanted to contract, they wanted to onboard groups, they wanted to build capacity through the provider, through these network capacity for CHWs or doulas. And so this natural flywheel effect happened. But then, of course, we can't just give them software and all of a sudden they were successful, right? We had to provide wraparound support. We had to help with contracting. And the contracting piece was what kind of led us to build out the provider network, the medical group. Health plans don't want to go to every single nonprofit and attempt to do a contract with them. They rather contract with one organization like Pear Suite, and we bring in a provider network that can now expand capacity. And we manage them, we support them, we do credentialing, we do claims for them. It just made sense. And we kind of did the opposite, right? In some states, we have 3 or 4 providers, we brought that to a health plan and says, hey, we're working with 3 or 4 groups. We have about 40 CHWs we're working with. Are you interested in partnering? And they're like, absolutely. We've been trying to do this, for months and years. And if you can help us contract with them and we can pay them. And so it kind of was this natural effect where if we can, manage both sides of this double-sided market, we can really thrive. And so the provider group kind of naturally came from that.
Yeah, well, first off, I compliment you for seeing that as an opportunity. We did a session, Healthcare 201, about a month ago, where we were working with PT, OT, and other therapies about trying to tap into the payment stream. The other thing you've talked about, which is really important for this group to hear, is how much of your work with your clients is trying to create sustainable payment models and revenue models for them, as opposed to just relying on grants or other contracts that are under attack at this point. So really, I think you guys, in addition, I'm sure what's good software and all that, you've done some really cool things on securing reimbursement and building out a provider. So I would highlight those two things as being pretty special that your firm's put together. So kudos to you guys.
Appreciate that. Teresa?
Teresa?
Yeah, thank you. So definitely appreciate your kind of one-stop shopping for CBOs and doulas and primatars, those organizations they face a lot of challenges. Have a question, and you alluded to this, and I think Dick actually touched on it. At the funding at the national level, where they're pulling back grants, they're stopping incentive programs, they're cutting Medicaid funding. I did notice you did have capabilities on like vaccines. So with the measles and the bird flu, what's your thinking around the funding and where you go from here?
Yeah, thankfully, well, a couple of things, right? So some of these benefits in some states are tied to kind of these waivers, right? These temporary, authorizations for reimbursement of services. Thankfully, in Kansas, it was a state plan amendment that passed the reimbursement. So Medicaid, somewhat, I think, is somewhat more safe than a waiver might be in a state where it's temporary. It may not be funded in the next, 4 years through this administration. Other things is, Medicare reimbursement's available. So we want to open up that funding stream for organizations that may work with older adults. We're also doing a lot of work to bring the community-based organizations to the health plans because realistically, health plans are benefiting a lot from community health workers, and they're willing to pay for this regardless of whether there's reimbursement or not. We're actually working in 7 states now that are doing reimbursement with health plans, even when there's no benefit. So there's no reimbursement pathway. For example, in Wisconsin, doulas can't get reimbursed for Medicaid, but the health plan said, we want to still fund this work because it's important, it saves us money, it improves outcomes, and my employers, the big people that are paying them a lot of money want to see it. So we actually help reimbursement for doulas in Wisconsin with the health plan because they know that it's important. So in Hawaii, a health plan is actually a commercial health plan is paying for community health workers, which is really exciting. So how do we tie the work of community health workers to these financial outcomes that's going to help make a difference, regardless if there's Medicaid reimbursement pathways or not? So we're trying to just bring those, two together and tie the work of community health workers. And that's the thing is community health workers don't realize, and I always tell them like, they're doing so much good work. Every time they help someone get a vaccine, every time they help them, get them to SNAP benefits, that's so much money. They don't realize how much money they're helping the healthcare system save. And if we can translate that work they're doing to financial and clinical outcomes, we can make a better case to health plans that they should be paying, for this all year long. And so that's what we love doing is kind of tying their work to ROI and presenting that case to health plans so they can actually fund this all year long.
Other questions?
Sherry, I saw your question in the chat, and yeah, that's a really good question. We actually, it's exciting. In some states we work in, the requirements for becoming a CHW or at least getting billed or billing through the CHW benefit is really low. So maybe I shouldn't say low. It's very accessible. So you can be someone with lived experience and someone with years of I think in one state it's 2,000 hours experience. You don't have to have a certification because they don't have certification pathways yet. So we're actually helping barbers in a barbershop get paid because they're doing health screenings with Black men before they get haircuts, and they give free haircuts for Black men to get before they do a health screening. We're helping high school students who are community health worker students get paid and reimbursed. We work with people of all backgrounds. We do a lot of work with the justice involved community, some of which have never graduated from high school. And sometimes their tech literacy is challenging. We want to make billing as simple as possible. I showed you kind of some screenshots of the really complicated version of our platform. We have a very simple version as well. We also have a mobile app. So you can actually get a billable claim just by logging your activity on our mobile app. It's simple as like saying who you met with, what you did, you answer some questions, you press save, and all of a sudden that's a claim. And make it super simple for you to get paid. Some organizations don't want to do intensive case management. They want to do really simple, like I'm doing a cooking class. I want to get paid for that. Let's make it possible. So we've actually reduced a lot of the documentation requirements. We fill in all the gaps for you, so you don't have to worry about place of location, consent, things like that. We take care of it. So yeah, we work with people of all backgrounds, and yeah, it was a big change for our team because we're used to working with groups that previously were know how to use Zoom, you know how to use. But when we met people that said, "Oh, actually, can you just call me? Or can you meet with me in person?" We had to adapt our implementation and support process.
I'm very glad to hear that because there are a lot of people who are on the ground that contribute to the improvement of health and getting communication, or what they call street media, and just supporting people from faith-based groups or seniors who are dedicating their savings or excess money to supporting community. And they're not as tech savvy, but having an app like that is fantastic. And I'm just happy to be here today to hear the good information. And will definitely go to community and share your um, information and program. Thank you.
Great, Sherry. Thanks. Kind of at that more practical level, Colby, are people just logging, and would the user just be logging in through a browser, or are they downloading an app? How's the kind of person approach it? And then the second thing is, many times we even the CHW may be making an assessment. Is that assessment something that can be loaded into the system such that the data are captured in a structured way?
Yeah, absolutely. So yeah, the platform allows you to document any question or collection of data that you want. So you can, if you want to use the prepare assessment, you can add that. If you want to have your own assessment and maybe you do a home, assessment with questions around, the ventilation, and if there's, mold, or if there's, good lighting, you can add your own assessment there as well. It's very customizable.
Okay,
Absolutely. Yeah.
that's great. Well, any other questions before we move along? This has really been a very informative session.
I did see someone in the chat, and I was
Okay.
gonna, let's see. Someone asked around, yeah, so Bill on behalf of a CBO. Yes, so depending on if you're billing through Medicare or Medicaid. So Medicaid, it doesn't require a visit with a clinician, but you need a referral, some kind of referral of someone saying this person has a social need, therefore they would benefit from community health worker services. The policy doesn't state that you have to have a formal relationship with that member. So you can actually have a clinician, a partner clinician that you contract and you pay on the side to say, hey, can you sign off on all these people? And we do that all the time. We have a clinician on our team that signs off for 1,000 people a week, basically. So that's kind of an easy one to get over. The Medicare side's a little more different. You have to have some kind of initial visit with the clinician. So that has to be documented before you provide services. And so these are the kind of things that, of course, you might not understand what it means by reading the policy, but when we break it down and we talk to our billing specialists, we find ways to get around things, and we kind of work around the policy. And so there's always a solution. We have to just kind of find, and sometimes the best way to do it is just poke around and try things and submit claims and see what happens. If you get denied, you ask why and you fix them and you resubmit it, and all of a sudden you figured it out. So yeah, we've learned a lot along the way.
That's great, Colby. We probably need to move. If you wouldn't mind, Colby, addressing Amy Roberts' question about working with state Medicaid groups through the chat, that would be fantastic. We'd really appreciate that.
Yeah, we'll do. And I can stay on and answer more questions if you have it in the chat. So yeah, thanks a lot again, everyone. And thanks, John, for having me.
Thank you, Colby. We really appreciate it.
Can Kobe put his contact information in the chat so that we can directly
He
interact
has.
with him?
Yeah, he has.
Okay,
It's just above Amy's question.
thank you.
Mhm. All right. It is my honor to introduce Dr. Mark Hoffman from the Children's Mercy Research Institute and Children's Mercy as a whole. Um, he has been a tremendous innovator, has a number of patents to his name, and is so respected in the community. For instance, he'll be kind of headlining the Midwest Informatics Conference shortly, and he has spoken and written very much through his career. And I'm looking forward to his discussion of how they're using geospatial analysis at Children's Mercy for kind of identifying where patients are really coming from. So, Mark, if you'd like to go ahead, please do.
Thanks, John. Thanks for the invitation. First of all, can you just confirm that my slides are showing in full screen mode?
No, we're seeing the presentation mode. So we're seeing one slide and then another recited.
Is
There
that
we go.
better?
That's it. Yep.
All right, thank you.
Hmm.
Great. So just want to take a little time this morning to describe some projects we're doing in the research informatics and data science team at Children's Mercy, focusing on geospatial analysis. I see a number of my friends and colleagues on this call, so some of you are going to be interested. This is a new twist in my work. But so why broadly, we're thinking about place-based logic. So those of you who have known me for a long time, you know my interest in the genome, but there's a parallel stream of thought that your zip code is as predictive of your health status, if not more predictive of your health status. So um, been putting focus onto that. Place-based logic's important for epidemiology, health services research, health equity research, which no matter what the funding picture, I remain committed to that. But it's also important for healthcare operations. So if you want to understand within our catchment, are we missing key portions of the population? Are we allocating resources in a geographically logical manner? Are we doing everything we can for positive patient experience? Geospatial analysis can be helpful for all of those topics and more. Um, there are a number of challenges in doing place-based analysis. The commercial software that's available to support this work is expensive. And some of my first examples will be based on those applications, primarily through Esri. They're also difficult to use. So working with the Esri applications requires a considerable learning curve. It's not accessible to just jump in and get started. There are some open source geographic information systems. Those are also fairly complex. There are command line applications, and again, there's a barrier to entry for those. Important for today's audience, I also want to point out that many people who do geospatial work will go to Google and they'll do their geocoding in Google. That is, unless you have a business associate agreement with Google, that's not HIPAA compliant. You're disclosing address to a non-covered entity. And so you have to really reflect on whether that's an appropriate action. So these are some of the drivers for the work that I'm going to describe today. I want to start with an example of a manual analysis that a member of my team did a few years ago. She has a PhD in economics, did that work at UMKC, and then came to work with me as a postdoc. And if you are paying any attention to news coming out of Children's Mercy, you may have heard about our Genomic Answers for Kids initiative, where we're trying to bring full sequence genomic analysis to the community, to the largest number of patients and in the community as possible in order to assist with rare disease diagnosis. When we did this work in 2022, there were about 2,200 participants enrolled in what we refer to as GA4K, Genomic Answers for Kids. And we thought, well, it would be interesting to examine the recruitment patterns for GA4K relative to what we know about the Kansas City community. And so we geocoded every patient, every subject in that study and mapped using heat map where they live. And so the map on the left shows the intensity of the recruitment patterns. And so the yellow represents where there's the highest level of recruitments, and then the dark blue is the least recruitment. Um, and so many of us know the demographics of Kansas City, and you'll see that recruitment strongly favored the wealthier, less diverse suburban areas. Um, we've included the truce divide, and you can see that really stands out pretty clearly here. And you can see, compared to other counties in our catchment, Wyandotte County had very low recruitment. So on the right is a map that shows the percentage of the population living below the national poverty level. And you can see it's almost an inverse of the recruitment map. Doing this work took months for Dr. Kane to perform both the data gathering and then the mapping and all of the fine tuning. And that really led us to think through, wouldn't it be nice if we could enable, beginning with researchers, to do the same type of analysis for any clinical trial, any research study, and to do that in a much faster manner. And so that really was the impetus for us to begin a two-step development process, um, all of which has been primarily funded by the Frontiers Clinical Translational Sciences Award. So Children's Mercy partners with KU on that. So there's two elements to the development that I'm going to share today. The first is what we call the self-service geomarker, and that's a foundational component to the work. And then the second is what we call the spatial cohort analysis and location explorer, and that's the actual visual application that we've developed. The self-service geomarker ingests a file of addresses and then securely converts those street addresses to coordinates. It sits behind our firewall, so it's HIPAA compliant. That's a key factor. So the self-service geomarker is built around a open source application called DGAUS that was developed by Cincinnati Children's Hospital. That's a command line application. So again, there's a barrier to entry where that's intimidating to many users. And we put a wrapper around DGAUS to enable this self-service. We also added features that are not natively a part of DGAUS. So we added an application programming interface, an API, so there can be automated streaming transactions with the system. And then we also added integration with our institutional identity management, our single sign-on. So this is the front-end user interface. So it's within our Children's Mercy branded portal. The user selects the file that they want to process. They pick the types of outputs that they want. So the geocoding generates the latitude and longitude for the addresses. Key thing for those of us thinking about health services, it provides drive time. And we allow the users to pick the site of origin that they want to examine drive time relative to. For social drivers of health, it provides census block output. So that's the user interface. And as I mentioned, it does integrate with our single sign-on, so it's fully secured. We built a admin portal so we can track usage of the geomarkers capability. The output's not very, you know, pretty. It's just a CSV or Excel format. But again, you can see that it takes these addresses. This is retail pharmacy, so we're always, you know, for demos, never want to show any actual patients, but we did want to show real addresses. And so this is an example of the raw output. For larger geocoding projects with thousands of subjects, there's a lag, so you receive an email indicating when your job is completed and the file's ready. We have monitored using that admin marker. We've deployed this internally at Children's Mercy, and then KU Medical Center has also installed the application. We've demonstrated different modes of deploying it. So our teams used Kubernetes in Azure. KU began initially with a VM in Azure. KU is not using the API. And you can see if you go down to the API results that Children's Mercy's processed 14 million transactions. Our patient progression hub, so this is where it's actually used in our operation. So it is actually a translational project where our patient progression hub uses this capability to geocode every patient going through Children's Mercy and use that to inform providers about social drivers of health. You'll have the same question I had. There's not 14 million people in Kansas City, so patients' addresses change. So periodically we rerun our whole cohort to determine whether an address has changed. But it's been really impressive to me to see both the research and the operational usage of the self-service geomarker at Children's Mercy. The second element is what we call scale. And so this is much more visual, and scale automates what my postdoc did manually, where it provides a user interface to bring in those geocoded addresses and then present them in a very streamlined interface to the user. So they go through a guided workflow and can seek those meaningful patterns. And again, this is just a demo data set. But so the first thing they do is they bring in their cohort. You can see them both as dots if you're allowed to see that, or heat maps if you prefer to obscure the exact location. And then they can examine the region that they select the region that they want to examine. And it can show both county or census tract. So here we're seeing census tract. And then the really exciting thing is the ability to bring up a second pane that shows the context of that cohort. And so as you zoom in and out, the two screens stay in sync. And then on the right side, you can see currently we're providing just some basic census-driven demographics on percent minoritized population or income standing. We're in the process of integrating the Child Opportunity Index as a third comparator, and we have a growing list of other drivers for the right pane that you see. But running through the type of analysis that this demo is showing can be done in about a half hour. So it compresses, a long amount of work to a much shorter time frame. Obviously, there's limits and there's things that an expert in GIS would still need to go to those commercial systems to do. But as an entry-level application to securely evaluate a cohort, we feel like this has been a really significant step forward for researchers at Children's Mercy. We also provide tabular summaries, so whatever your cohort is, if the input file includes demographics, we can show how your recruitment demographics compare to what's known down to the census tract level. So again, very, very geographically precise information at the tabular level. And then we also allow users to export the maps or the table data for use in publications or other purposes. In 2024, we processed 6,500 addresses in scale. And we're in the process of working with KU Medical Center to complete a license for them to serve as our beta tester, and that's in process. So just to conclude, GeoMarker, DGAUS has a viral open source license, so GeoMarker has to be open sourced. It's containerized. It is live at Children's Mercy and KU, and we have a manuscript under review describing GeoMarker before we start to promote widespread adoption. For those of you who are interested or curious, it is containerized, so we've learned in working on our initial deployments that that's not always intuitive for groups that are trying to install software. So if that's something that you are comfortable with, then you're probably poised and likely to be able to do that. We're working through we have a third installation site that's in process. It's very exciting to us, and working through some single sign-on integration challenges with them. Scale is live at Children's Mercy, and then as I just mentioned, we're working on an agreement to deploy to KU. We have a patent pending on Scale, and we're still evaluating different licensing and even potentially commercialization strategies for Scale. And then, of course, I want to recognize and acknowledge the team behind the project. So this is the research informatics and data science team at Children's Mercy, and I think many of them have touched the two initiatives that I've described, and so I want to make sure that appreciate and recognize all of their work. And with that, I'll stop and be happy to take any questions. And just a shameless plug. John indicated the Nexus Informatics Conference, so that's coming up in a couple weeks. I've had the opportunity to chair this conference for more than 10 years now, and it is a smorgasbord of informatics. So if you're interested in a wide variety of informatics topics, come join us on the 10th and 11th. Thank you.
Thank you, Mark. That was great. Really appreciate it. I had just a really simple question, and that was, you had mentioned the Child Opportunity Index. Where does that come from?
I believe it's managed by Cincinnati Children's Hospital as well.
Okay.
It is users of Scale who may want to integrate COI. They will have to have their own license with the organization that manages the COI, but we're structuring it so that should be simple to accomplish.
Okay. Others have questions for Mark.
Yeah, this is Doug Hohulan. Great presentation, Mark. Thank you. One question I have is so how many hospitals, children's hospitals, are using something like this? I mean, are you kind of leading the way in this area? And do you see this growing beyond the Kansas City area and the other hospitals?
Yeah, absolutely. The third site that's installing, and again, I'll keep the two things distinct buckets, but the GeoMarker, the third site is outside of Kansas City. And so, yeah, we're we're expecting once the paper comes out to get a lot of interest in the geomarker. We need to figure out our support model for that, because it has taken some work from our team to support KU and the other site in getting installed. But, I think we designed both with really no design elements that are specific to Children's Mercy. We really want both of these to have widespread adoption and use. And part of the value of the CTSA network is, once the publications come out, they'll, I'm sure, be very active in promoting both of these.
And will this be beyond just children? Will this be useful for adults too?
Yeah, there's no, other than the integration of the Child Opportunity Index, there's really nothing that's specific to pediatrics in the way these were designed.
Thank you.
Sure. Good
Okay,
question.
Teresa?
Great. Yeah, thanks, Mark, for your presentation. Quick question. You had mentioned that KU is not using an API. Will that change when they implement Scale?
Yeah, and they're actually re-implementing the geomarker as the component that has the API. And I believe that they're actually re-implementing geomarker to make broader use of the features. And I think that'll be part of what's activated. If you're familiar with Jeff Thompson, his team is working closely with my team on that.
Yeah, great. And then a follow-up question. How has this, or do you anticipate it impacting clinical trials and research studies?
Yeah, so consistently in research, the researchers will have an intuitive sense of whether their cohort is representative or not. This will enable researchers to have a much firmer footing in making that assertion. So, picture's worth 1,000 words, and a map, I don't know how many words a map is worth, but it's just so intuitive and so accessible to see. It quickly tells a story, and I think so it'll take researchers from that intuitive sense for whether their cohort recruitment strategy is reaching all elements of the community that they intend to or not.
Mark, you had said that the patient progression hub is using this. So when they do, and they draw someone from a particular census tract, then they're making assumptions that they kind of know what sort of circumstances apply to that person. Is that how they're using it?
Yeah, and there's a lot of good things behind your question, John. I see two general strategies for social drivers of health. One is a questionnaire where you ask the patient, do you experience food insecurity? And that's an important approach, but it adds to the burden of the clinical encounter. Whereas this approach is we can infer some things based on what we know about where you live, but that doesn't mean that we know exactly whether those apply to you specifically. And so the Progression Hub team does a good job of recognizing that limitation of the geospatial approach, but also recognizing that it's very efficient in terms of if 80% of the population in a census tract experiences food insecurity, there's a likelihood that the family that they're looking at may have that risk. So, but they still have to contextualize that information.
How does that get flagged on the chart?
Remove the
It's not on the chart. It's the hub is more of a dashboard for patient flow. And so
Mm,
they hover over a patient in the hub. There's a pop-up that if they choose to see it, displays that information.
I see. Okay. Thank you. Others? Go ahead, Dick.
I'm sorry. Does somebody else want to grab that?
No, go ahead, please.
Yeah. So first off, Mark, it's always great to see you, and I'm excited about the informatics conference, BioNexus, which works with Mark on this. A lot of great presentations, and I would encourage folks that have an informatics bent. One, Mark is both showcasing a lot of the regional expertise, and also bringing in some national class speakers. So I think it'd be great to, if you guys got some time, go out and check out the website on it, and hopefully get registered and visit with us. Mark, I looked down the road a little bit, so this will help you gain insights into more communities, come up with different community health worker strategies to go out and encourage families to participate in this. Where do you think this is in 5 years, given what we know about AI, privacy? There's a lot of things we could throw into the mix here, but this is kind of, having worked with you early in your career, knowing kind of how I don't want to say I know how you think, but I have thoughts about the way you're not just doing this for a point in time. How does this all come together? Your work in genomics, your work in community and predictive health and those things. Tell us a little bit where this ends or
Yeah,
where this heads towards.
sure. Couple of responses. One is to the credit of the Genome Center at Children's Mercy, they took the manual study and they really made an intentional effort to reach the areas that they weren't successfully recruiting from. So they modified their recruitment strategy. So just in terms of, one of the things I believe is that health equity requires research equity. And so if the patient and if the cohorts we're incorporating into research aren't representative, then the research coming out of that work won't be as representative as it needs to be. So that's one fact. The broader driver, it for my broader vision of things I'm doing is a term that I use is the envirome. So applying a data science mindset to patient context, it's complementary to the genomics and proteomics, but developing a toolkit that enables us to really drill into a patient context and topics where in many cases there's a shorter path to a successful intervention than there are for the pure biology plays. Um, so I see these applications as part of the necessary toolkit to understand patient context. So one thing we've done at Children's Mercy that preceded this work, but it's also kind of now we want to go back and it's what we call our Envirom web services, where we um, geocode all the patients, and in our chart we show whether that child lives in a food desert. And so we don't require the providers to go look for that. We anticipate it and make it available at their fingertips, using this mindset of automating the process of describing patient context.
Can I ask a two-part question? Um, the word food insecurity, would a individual know what that meant?
Yeah,
We
great
use
question.
it as
And
a medical term. And then the
yeah,
second part of that is, do you think that would be too big of a generalization if you say because of the location of someone or where they live,
mhm.
they are a part of a food desert or have food insecurity? You know what I'm saying? Like, is that because with healthcare, that big generalization could sometimes bite you
Yeah,
in
no,
diagnosing or
Yeah.
categorizing someone.
And, that gets back to the themes that I raised after John's question, where the questionnaire approach, and I appreciate you uh, keeping me accountable for the actual language is more often, um, did you have more than one meal today, or things that are more accessible to a wider range of patients versus do you experience food insecurity? So the actual questions are more likely to be framed in a manner that's clear. And that'll get you specific information for the patient in front of you, which has really significant value. The complementary approach of, if we're not asking that questionnaire or we can't add the time, is it still useful to know that a patient lives in a region where the region is a food desert? Again, it doesn't mean that they individually experience food insecurity, but as a provider, should we be more likely to then proactively ask questions that would confirm whether that specific family or patient experiences food? And so, and it's the whole process of how to do that is another unmet opportunity for research, because it's a emerging way of thinking. And so we're the first to say we don't have that all figured out, but we're just trying to equip providers to, especially if they can't add in the time to do a questionnaire, to equip them to adopt or adjust their conversations based on um, the greater likelihood that a particular patient may live in a food desert.
Do you think creating that approach could be a problem in healthcare if people don't have time and they do a broad assumption based on,
Yeah, yeah,
not specific data to the individual, but because let's say the river market doesn't have grocery stores, but it does have um,
yeah,
the city market on Saturdays, but you
mhm,
have to drive a considerable way.
yeah,
And that's kind of a high end area of renters and wage earners.
yeah. Um, Again, these are all things that are constantly on my mind. And one thing we do at Children's Mercy, and we've done with some of these initiatives, is we bring them in front of our community advisory board to get feedback, so that we're not, you know, we never want to take a step backwards when our intent is to be more supportive of a wide range of needs. I think um, many provider, providing providers or offering providers the means to um, access this type of information without having to go seek it. Um, we still think will be helpful, because um, so it was interesting when we did a design for this. We did a focus group and we put like 10 to 15 different social drivers in front of the providers, because we thought they might be informative. Of those, food desert was the only one that they felt they could be actionable in their clinical conversations routinely. So, um, we've tried to be really intentional about selecting what and how we put into the system.
Great. Thanks for your question, Sherry.
Oh, you're
Um,
welcome. Thank you for
Thank you.
no,
ex-
glad you did. Thank you. Doug.
Yeah, another question I have, I'm very interested in AI literacy. but also health literacy. And there's data that says that there's 10-year difference between someone who has high health literacy versus low health literacy. Another on health literacy impacts a healthy living by a factor of even 20 years. So do you track, is there a way to track health literacy in your data? Either the family. Now I know for children that's hard, but how do you consider health literacy? And that's something I'm very interested in on how AI can help with health literacy.
Hmm. Um, I don't know that the geospatial work is going to offer a lot in terms of the health literacy, other than um, to the extent that somebody may use this and generate a map and incorporate that map into a conversation. It may help with that conversation. Um, I think, you know, with regards to AI, some of us are involved in the ethical AI initiative of the Center for Practical Bioethics, and there's wide recognition that AI should be trained with representative data, but the developers of AI rarely, if ever, know how to do that. And so another one of my thoughts on scale is it can and should be used to evaluate the data sets used to train AI, so that gaps in those data sets can be recognized before asserting that your training set was or was not representative. So I see that upstream value for scale. I'm not, again, I don't, as far as AI literacy, I'm not sure there's a
Well,
specific.
not so much. I mean, knowing how to use AI is one thing, but then applying it to health literacy to make sure that
Yeah.
you understand what you can do to maximize your health as an individual. Also, I think I've seen that, especially young people, maybe not children, but teenagers and adults, or maybe young adults, like 80% of the time they use AI to help diagnose
Right.
a problem and then maybe even treat a problem.
Yeah.
And that comes with positives and negatives consequences. I mean, it's good when the treatment plan is a good thing, but it's bad when the treatment plan is something that would do more harm than good.
Yeah. No, it's a topic that's interesting to me, but I don't see a direct line between the geospatial work that we're focused on today. So I'd be
Okay.
happy to chat with you more about that.
Yeah, I can send you some information. I'm doing like the U.S. House of Representatives bipartisan task force had
Mhm.
a focus on AI on all the sectors of the economy. One of them, there's like 20 pages on healthcare, and one of the focus was specifically around diagnostic and errors as well as treatment errors in general, and then what could AI do about that?
Yeah, no, I spent a lot of time on that topic, but not so much in the geospatial context.
Okay, okay.
Great. Well, let's take one more before we close out. Teresa?
Great, thank you. I know we're coming up on time. Have a question. Do you tie the insights that you're getting from your geospatial work to feed that back to Children's Mercy Population Health? So, for instance, using, say, Intervaser to search for others and identify children for early, screening and intervention.
Yeah, we're doing a high level of internal outreach, including to our integrated care solutions, our community group, just to encourage them to try the suite of applications to understand their cohorts. And that it gets back to the healthcare operations value of what we've developed. I the For me, very intrigued with the drive time, because I think access to specialty clinics, especially for patients who may be in rural areas, can we use rigorous analysis of drive time to inform scheduling, or do we offer hours? at some of our smaller satellite sites more often in order to address those needs where we can reduce the drive time and access issues.
Okay. Well, thank you so much, Mark. This is so neat to see. We've 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 engaged children's so many times through the process of the health innovation team because of the levels of innovation you guys drive. And this is just a classic example of that. And we're very grateful for your time and sharing it with us. I think we'll take that to close out. Thanks excuse me. Thanks again to our presenters, and we look forward to seeing you all at a future event. Take care now.
Thanks, everybody.